Right.
Good afternoon and welcome to the Emergency Care Information Programme webinar series, covering the range of topics to support delivery and urgent and emergency care services across the health social care system. Although designed to support the 28 ESIP systems, information contained within these webinars is relevant and open to all, so please feel free to share with colleagues. Today's webinar is on mental health crisis care called Concordat, and that will be delivered by Dr. Robert Holmes, who is a consultant psychiatrist for Coventry and Warwick Partnership Trust. However, before we start, there are just a few simple housekeeping points. This webinar is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of this presentation, there will be the opportunity to ask questions. If you have a question, please use the raise your hand option on the panel on the right-hand side of your screen. Alternatively, you can write your question in the question section on that panel. During the question and answer section, we will unmute you to ask your question in person. If you do not have the audio enabled, we will pose that question on your behalf. Thank you. And I will now hand you over to Dr. Holmes for today's presentation.
Right, thanks very much, and thanks for asking me to deliver this presentation today. Good, if I can get it to work. Okay, right. So today we're going to talk about the Mental Health Crisis Care Concordat, and what I'd like to do is to give you an overview of the Concordat. I've taken the view that I'm speaking to people who don't know too much about it, so we're going to do an overview where I'd like to talk a little bit about the composition of the Concordat, what it's about. We're going to talk a little bit about the drivers that have driven the creation of this and that hopefully will drive the delivery of this. I want to look with you at the four main focus areas and then look at examples of practice and innovation within each area, just to give you a flavor of the work that we hope will progress from this. I want to look at the implementation and how we're doing, maybe talk about a few successes that we've had, and certainly spend some time talking about the challenges that this poses, because this is a large undertaking. This is a national undertaking and it encompasses a massive range of organizations. So, without further ado, the Mental Health Crisis Care Concordat was published by the previous government in February of 2014, and essentially what it sought to do was to bring together a range of organizations and get an agreement between services and agencies involved in the care and support of people in mental health crisis. It endeavors to set parameters for how people should work together and the standards of care that people should provide. What it hopes to do is to offer a joined-up network of services that will provide both prevention and treatment and rehabilitation-focused recovery service to people in mental health crisis. It was launched in February 2014. Initially 22 national bodies were involved, and now there have been 27 national signatories who have signed the Crisis Care Concordat on behalf of their national organizations. And there's a large diversity of people who have done this. Certainly associations of ambulances, police services, the various NHS Confederation, NHS England providers, the clinical commissioners, fire officers, health education, the Home Office, Mind, the Ministry of Defence, Monitor, and of course CQC have done a very good piece of work to support this. But most importantly, the third sector and charity supporters have really signed up to this, and we've got a range of third sector providers who are very involved, from Stonewall to Turning Point to Recovery Focus, National Housing Federation, Mental Health Providers Forum. So a large range of organizations who have pooled together resource and a significant amount of time to attempt to put together a overarching agreement to deliver crisis care, which is really encouraging because, as you're probably aware, crisis care in mental health has been something of a fledgling for many years, and while we have had crisis services, these have never been delivered in a cohesive and a joined-up way. And of course, it's so much more than purely focusing on the crisis. It's focusing on prevention, it's focusing on diverse things like housing, accommodation, employment, that we need to join up to provide a network for patients in mental health crisis. Right. So what are the drivers then? Well, the principal driver behind all of this was in fact the police. The police were very concerned over a period of time, as I'm sure many of you are aware, with reducing the number of people with mental health problems detained in police cells awaiting assessment by mental health professionals. And there were a number of high-profile cases and litigation against the police around injuries sustained or indeed deaths while in custody. And there was a huge movement by police forces across the country to do something about this, and this in many ways provided some of the impetus into creating the crisis care Concordat. We also would be looking for a dramatic improvement in service responses for those experiencing mental health crisis, and we want to provide early support in the community for people in mental health distress as opposed to mental health illness. We acknowledge that people are distressed, and that distress, if not addressed, if they don't get help, can easily develop into a full-blown mental health crisis, and it would be really good if communities across the country could have systems in place that would provide early enough to support to divert this from happening. The Crisis Care Concordat is centered around a joint statement, and I'll read it out with you. We commit to work together to improve the system of care and support so that people in crisis because of a mental health condition are kept safe and helped to find support they need, whatever the circumstances in which they first need help and from whichever service they turn to first. And I think that's really important because many of these patients turn initially to community-based organizations a million miles away from mental health, and they need that help and support and focus from those organizations. We will work together and with local organizations, again local organizations really being the important ones, to prevent crises happening wherever possible through prevention and early intervention. We will make sure we meet the needs of vulnerable people in urgent situations, and we will strive to make sure that all relevant public services support someone who appears to have a mental health problem to move towards recovery. Jointly, we hold ourselves accountable for enabling the commitment to be delivered across England. So really aspirational, but very doable in many ways, particularly when you break it down to a local level. All it needs is a commitment from all of us to take this forward. The Concordat as a document focuses on 4 main areas, and I'd like to go through these in a little bit of depth in the next few slides, but these are sort of the headings. We need to provide access to support before crisis point, and I think that that is fairly self-explanatory, making sure that people with mental health problems can get help 24 hours a day, and that when they ask for help, they are taken seriously. Too often we have people asking for help and they are fobbed off with pull yourself together, you don't need to be here, why don't you go and ask the pharmacist? And people who are in this degree of distress need to be taken seriously. We need to provide urgent and emergency access to crisis care, and that crisis care needs to be delivered with the same urgency as physical health emergency care is done. And that's a big ask because, as we know, there's a large gap between mental health delivery and physical health delivery, and we'll talk about that in a little while. We need to look at the quality of treatment and care when in crisis and making sure that people are treated with dignity and with respect in a therapeutic environment. And I think we would all agree that that is something that needs to happen. And of course, the major part of this, and away from all the urgency, is the need to help people to recover and to stay well and to prevent future crises from happening, making sure people are given the appropriate support services and networks that they can tap into. because essentially much of this is focused around on social care, particularly the recovery and staying well outside of the control of health services, but really within the focus of the Concordat. So I'd like to go through some of these points in a little more detail to give you a flavor of what is available or what we think should be available to people in these various 4 headings that I've just discussed. So the first one is access to support before a crisis. Well, one of the first things that we do offer, and we offer nationally on the 111 service, and of course the 999 service if it really gets to a crisis situation, are helplines. There's a diversity of helplines. Many mental health trusts run their own helplines, and big organizations like Mental Health Matters exist and run helplines for a number of trusts. Patients or people who have concerns can access these helplines and will be signposted towards appropriate contacts if it is felt that this is what is required. A number of trusts have also set up general practitioner helplines, which we aim to provide direct access to a consultant psychiatrist for general practitioners who may seek help in assessing or treating patients in the community. And certainly in my trust, we've been running one for 6 or 8 months. This has been fairly successful, with GPs phoning 3 or 4 times a day, asking for a diverse number of questions around medication, how to deal with people in certain crisis situations. It has been such a success in the number of trusts that have implemented this that I understand there's a private provider who's now attempting to market this as a saleable service. The second point is the education of primary care providers, which again is hugely important. We know that 1 in 4 patients within primary care have mental health issues, and we need our primary care providers to acknowledge their responsibility in assessing these patients correctly and holding these patients correctly and referring correctly. The knee-jerk reaction of moving everyone who appears to have a mental health issue into secondary care or looking around for secondary care help is one that overwhelms services, and we need to be educating our private care providers. We need to be educating our primary care nurses to provide a level of support before this becomes an urgency. Suicide prevention strategies. Since the Concordat has been brought into play, certainly local authorities who usually have suicide prevention strategies, often that haven't been updated, are dusting off their strategies, and there has been a surge of interest in providing updated and more contemporary suicide prevention strategies, because a lot has been done in suicide prevention over the last few years. We've seen some really innovative work being done. Certainly the British Transport Police, together with Samaritans, have put together some very successful suicide prevention strategies around the railways. And of course, many of you might have heard of the Detroit model of suicide prevention from America. We've had NHS personnel going across for training, and this has been rolled out in some areas in the UK. But the results from America are quite astounding in many ways. The Ford Clinic Foundation started a project in Detroit where they started screening patients who presented with a variety of physical issues for depression, and most importantly, then initiated treatment if that screening was positive. They didn't refer them on with an 18-week wait for secondary services. They initiated care, and the results have been really, really, really remarkable in many aspects. The national average suicide rate in America is around 230 people per 100,000 population, and Detroit, which is a really impoverished area with a lot of social needs, has got this down to 16 per 100,000. So really aspirational stuff, and something that we should be looking at a lot more carefully, and looking at how we can take the best of that and trying to apply it here. And that of course straddles both primary care and secondary care. Another great opportunity that we have to access support is by looking at identification of adult safeguarding issues in the vulnerable. Often safeguarding issues come to light only after patients have had a crisis and are absorbed into services. I know it's a big ask. Local authorities' budgets are slashed, and they've been really slashed. I don't have to tell you, in the last year, and will continue to be so. And safeguarding should be one of those issues that are ring-fenced, because if we can provide adequate safeguarding before the issues, identify the issues, provide people, often not with a huge amount of support, but with enough support just to hold them and contain them in the community, it will stop them lapsing into a crisis, often a social crisis, but dressed as a mental health crisis, because that is the way they can access help. There have been a lot of innovative IT-related projects like the Big White Wall, which you might have heard of, and if you haven't, you can Google it, and there's a really good website that you can see how this works and how it provides a variety level of support, particularly aimed at younger people to access both individually tailored support and also some individual support online. And there's a range of mental health apps. Many mental health trusts have brought out their own apps. Our mental health trust has brought out a range of 4 or 5 apps that have been developed by our psychologists. And again, these provide some really good, simple resources for people to use to help them to reduce anxiety and to take control of difficult situations. Peer support networks are very much old news, but they have certainly enjoyed a modicum of improved support in recent time with social networks online, and I think that that is something that we would be looking to develop in time. And of course, quite importantly, while it is probably not really relevant in access to support before a crisis, we should really be looking at secondary care mental health waiting time standards. The current standards are pretty long, and if we want to have an effective service that will intervene earlier in mental health issues and again prevent crises from occurring, we should be looking at realistic waiting time standards. If we look at urgent and emergency access to care, there's a range of issues that really need to be addressed to make this something that will work. We need to look at the integration of acute care services to support those with mental health needs. For far too long, people with mental health urgent issues have been streamed away from urgent care services, awaiting secondary care mental health services. We need to make sure that our urgent care services around police, ambulance and emergency departments have training around coping with patients in crisis and knowing how to deal with them and to signpost them. There's been a lot of mental health training of police which has been really successful, and there are a lot of joint initiatives between police and health which I can share a little bit about with you in due course. Ambulance services have embraced training, but again there's a big ask. There are large organizations, and while many of the paramedics and higher skilled technicians have got excellent mental health training, a number of their staff still require training of an adequate level that will help them to deal with these issues. Emergency department staff, while we've got psychiatric liaison services built into many ED departments at the moment, we do know that there is a significant gap in many of the emergency department staff's understanding of mental health issues and dealing with mental health patients. Part of the remit of many liaison services is to provide this education, and where that is done well and where that is done repeatedly over and as a rolling program, we see significant improvement. I'm aware that in the Midlands there's an initiative to look at education of emergency department staff on a more structured basis across the region, and we look forward to that happening over the next year or so. Provision of places of safety, again at the core of much of this, as I said earlier, was the notion of police not wanting patients in custody with mental health issues, purely waiting for mental health assessment. And mental health places of safety have been rolled out over the last few years and will need to continue to be rolled out, and I'll talk a little bit about them in a few minutes. Police and health collaboration we've spoken about, and that is really epitomized in the street triage process, And again, I'll talk to you in a few minutes about that. Information sharing sounds really basic, and it's something we do terribly, in my opinion. We don't share between primary care, secondary care, mental health. We have really difficult situations about getting information. During the day it's a little better, but at night it's often appalling, and we really need to be addressing this, and part of the Concordat's work is to look at ways that we can do this. So urgent and emergency access to care around provision of 24-hour mental health structures outside of mental health hospitals, because clearly, certainly in most mental health trusts, less than 8% of the caseload will end up in hospital at any one time. So services are delivered outside in the community, and we have a range of teams that we've built up over the last probably 15 years that will address crisis situations. Crisis resolution home treatment teams have been around for the last 13, 14 years. There are about 345 of them across the country at the moment. And they exist for a number of reasons. They exist to provide a quick response to people in crisis and then to follow through with home treatment packages if needed. They exist to provide an alternative to hospitalization. They exist to provide a reasonable front door to acute mental health services. And this is done variably across the country. We have some excellent services, we have some less than excellent services, and one of the issues that the Concordat is going to seek to address is to try to standardize care. Most crisis resolution home treatment teams will provide a response within 4 hours of referral. This is not a blue light service, and often it is sold as such to patients, but it is really not. Mental health liaison teams, psychiatric liaison teams are in acute hospital settings, and they are generally active in the emergency department in many hospitals, and in some hospitals are active in the wards as well. And we would hope that those two would go hand in hand. I'm aware that commissioning tends to lean the way of urgent services, and that ED departments generally are covered, but we need to be looking at the wards, because equally we've got patients on the wards with significant mental health morbidity that needs to be addressed. What has been particularly helpful in the last few months has been the department requesting that CCGs commission 24/7 liaison services. This has been taken up in many areas. In some areas there's still a significant lag despite the guidance and despite the evidence. Street triage teams have been one of the success stories, and I'll give you some information in a few minutes to support that. Essentially what this is these are teams of band 5 or band 6 nurses, and at night, usually at night in the trust that I work in, we provide a service from 5 o'clock at night till 2 in the morning, where a nurse is based at a local police station with a policeman and sometimes a paramedic, and they provide a first response to people phoning the police with what appear to have a mental health bias to the complaint. There have been significant gains in a reduction of presentation to places of safety as a result of this, and they have helped enormously in avoiding admissions. There was an initial pilot across 7 or 9 areas across the country, but many other areas are rolling this out. Obviously, it's easier to provide this sort of team in an urban area, and that's where the most success has been, but we are looking at different models for rural areas where we are placing nurses in police control rooms, and with video linkage, we can actually get the nurse to be speaking to the constables on the ground and to giving them advice in rural areas, which again is a great step forward. We've introduced criminal justice liaison teams. These have been around for quite a long time, but we've realized that we can't do this as a 9-to-5 service, and this has been extended in many places. So we will have a team of generally band 6 or above nurses based in the cell, in the custody suites, based in Magistrates Court and the Crown Court, looking to assist people who appear to have mental health issues within the criminal justice system. And again, this has proved to be successful. And then in a few places in the Midlands and elsewhere, we've seen the development of psychiatric assessment units. These were popular sort of 15 years ago. They lost popularity, and they are certainly coming back with a slightly different focus around more acute care, and that I think is something we would need to explore. It's interesting that in the Midlands there are 4 trusts that have taken on a part of the Vanguard project. It is the only Vanguard project centered around mental health, and we are looking at the provision of acute crisis services for mental health and trying to get a standardized care with 7-day working for these services across 4 trusts. So that would be something that we could look to for some modelling in the future, I would hope. The quality of care in crisis, well, standards for crisis care need to be developed across all sectors, and certainly this Vanguard project we hope is going to deliver some of that. We need to be looking at an extension of liaison crisis teams and places of safety for children and young people. Less than 40% of CAMS, child and adolescent mental health services, have rapid access through crisis pathways. That was 2013. There's been very little progress on that to date. We are currently looking at provision of places of safety for children and younger people, but this requires some investment. Improving uptake of crisis care in minority groups. Again, minority groups have been slow to access crisis care services, and work is being done to look at how we can address that. The role of voluntary organisations has been significant in providing a good quality of care in crisis, and we need to support this, and we need to be working with voluntary organisations and third sector organisations within our crisis home treatment teams and bringing them together. Again, crisis houses, the provision of support for people, particularly in social care crisis with a mental health bent, were very popular. Recent cuts in funding has meant that many of these projects have disappeared or have been downgraded, and that has been a tremendous loss. Having somewhere for someone in crisis to be accommodated for a night or two under the supervision of perhaps a crisis home treatment team was previously invaluable, and we really need to look at how we provide a similar thing again. And of course, the support of carers cannot be underestimated. When we go in and home treat someone, we are there for perhaps, if you're lucky, 30 minutes, 40 minutes a day. The rest of the time we rely on carers in the family, friends, partners to take care of people who often are very ill and who require a significant amount of care around behavior modification, around providing boundaries for their patients, for our patients, and this is delivered obviously by unpaid carers, and we really need to support them a lot better than we do now. And then the fourth sector, the fourth function of the Concordat is to address recovery and staying well, looking at effective discharge planning, crisis planning, so patients know that when they enter into a crisis or when they feel this is happening, they know what to do, who to phone. We need to be looking increasingly at access to social care support, housing, employment and empowerment programs. We need to be looking at robust outcome-based third sector commissioning. I think there's wide agreement that third sector commissioning in the past has often been fairly hit and miss, but again, I think we're moving into an area now where we know what the high level of care third sector can provide, and we need to be commissioning accordingly. We need to be looking at the integration of substance misuse programs into mental health and being delivered as a stream within the crisis pathways. Having substance misuse sitting outside of this is absolutely meaningless, as many of our patients who have mental health issues have significant substance issues as well. And of course, fighting stigma, that tends to go across the whole spectrum of what we're talking about. And as you may be aware, the Royal College of Psychiatrists have been active in the Fighting Stigma campaign for some time. So how are we doing? Well, on the Crisis Care Concordat website, you can see a map of England, and you will see that the various localities have been color-coded. This was red, amber, light green, and green. And fortunately now, sort of 18 months into the project, We have got an overwhelming number of dark green localities, which means that they have an action plan which is approved and published, and we have a few light greens, particularly around the south, where we have action plans approved but not yet published. And there is a bit of a difference in areas. Many of the light green areas have very complex commissioning arrangements. Central London, for instance, will have several commissioners talking to a range of mental health providers, talking to a range of police forces, and it makes the agreement around a crisis concordat particularly difficult, but something that is being attained slowly. So briefly, some successes. I've alluded to street triage and places of safety. In 2011-2012, we had nearly 6,500 recorded cases of police custody being used as a place of safety, and that has dropped to about 4,000 last year. So a really good reduction, 54%. Excellent, and that's largely due to provision of health places of safety. We've got a reduction in the use of 136 in adults. This is probably around street triage successes. West Yorkshire showing a 26% reduction, Thames Valley a 39% reduction. So again, some real success with street triage. Children cases of Section 136 have reduced almost by, well, certainly by 100 over the last 2 or 3 years. There's an incidence of more appropriate hospitalization around Section 136 arrests increasing, and turnaround times in assessing people with 136 suites are reducing. So now, hopefully in many areas, under 4 hours. A big challenge for the places of safety is around dealing with intoxicated people. This group of people were generally not accepted into places of safety, but increasingly commissioners are looking at ways of getting intoxicated people to be taken into places of safety rather than into busy A&E departments. And while there are significant challenges around this, I think there's general agreement that we need an area where people can be looked after safely and then assessed if necessary. Just a brief word about the Meccan Interim report. I had hoped to talk about their final report. The Meccan research organization has been asked to do an assessment of crisis care concordat implementation, and we are waiting for their final report, which is due to be published very shortly. They did an interim report in last year, middle of last year, which picked up 5 themes of issues in getting the Concordat established, and those were around looking at the leadership and stewardship of the Concordat on a local area level, and how some were being police-led, others were being CCG commissioner-led, others were being user-led, and looking at some sort of consistency and approach. Again, looking at issues around partnership working. Often we have long-standing relationships in partnerships with local authorities, mental health trusts, acute trusts, but many of these need to be reworked in view of the needs and requirements of the Concordat. Regional boundaries are an issue. We have different police boundaries to local authority boundaries to health boundaries, and this causes some problems that have to be worked through around where patient responsibility lies. I don't think that they are overwhelming. However, on a local level, there seems to be a lot of difficulty in resolving some of these issues, and also the issues of where services will go and will not go. Approved mental health professionals who conduct Mental Health Act assessments are very tied to local authority boundaries, and that, we believe, causes at times unnecessary delays. We should be using our resource of people with these skills more widely and more consistently. We need to be looking at competing priorities, and clearly resource implication is a real problem across the service at the moment. But again, most importantly, the 5th theme is around how we involve our service users and carers in this Concordat. Right, other implementation issues that come to mind. We I am aware of a number of areas with looking at the Concordat as a listing exercise, focusing on existing services with so far little attempt to move the agenda forwards. That's really not in the spirit of things. This is an active plan that needs to be moved forward. And while we need to list and we need to stratify what has gone on and what we have, we shouldn't be spending too long in doing that and using that as a basis to move this forward rather than as an end in itself. We have real issues with mental health resource shortfalls, as I'm sure we can say in physical medicine as well, but there are very real issues. How can a crisis team have a waiting list? At times, the crisis team I work in, when it's particularly busy, we might be seeing someone 3 days after they've presented. How can that be? And we are fully staffed. It is just really not acceptable, and we really need to look at how we address some of these resource shortfalls. Banging on the drum of lack of parity, which is obviously a psychiatric favorite, is the lack of parity with physical health. We know that mental health issues are around 22-23% of the disease burden of the UK, yet we receive 11% of the budget. And I'm sure there are some very good reasons for this, although they're not particularly apparent to many of the mental health professionals that I work with. And of course, I've mentioned information sharing, which is an issue. What we need to do really is to maintain the close alignment between the Concordat and NHS England's parity of esteem agenda, and providers must recognise that the risks of emotional harm are as real and life-threatening as those of physical activity, and that comes from the CQC of their Right Here, Right Now document, which is a really useful and live document which was published recently. We need to be looking at accountable commissioning, looking at the adequate funding of the right service at the right time. We know, for instance, that patients presenting with mental health issues at the emergency department tend to present between about 3 and 4 in the afternoon and 3 or 4 in the morning. So it makes little sense for a service to be commissioned, a psychiatric liaison service to be commissioned from 9 to 5 during the day. And it sort of beggars belief that we ignore the evidence and we continue to do this sort of thing. But what we really need to do, I think, is to embed the mental health crisis Concordat at the heart of the local system resilience groups. Because mental health is a whole health economy issue, and if it's not part of the resilience groups, then I think a huge opportunity is being lost. So thank you for listening. I'm sorry I've overstepped my welcome by a few minutes. I'm happy to take any questions that you might have. Thank you.
Thank you, Dr. Holmes. That was really interesting. So if anyone has a question, they can put their hand up on the panel on the right-hand side, or alternatively, they can write it down. We also will give you the opportunity to ask questions once the webinar has finished, and you can email us at ecipinfo@nhselect.org.uk, and we will then get your questions over to Dr. Holmes, and we will hopefully get an answer for you that way. So I'll leave you for a few minutes to decide if you have any questions. So we have a question from Eva. She says, thanks Dr. Holmes, this has really been helpful. Could you talk us through the current national standards for mental health?
Well, the national standards for mental health are fairly diverse, and I suppose what we are trying to push for are national standards that are congruent with the sort of work that we are trying to do. We have standards around 18-week waiting lists. We have standards around 4-hour times for crisis intervention. We have standards around early intervention, which have recently been reviewed. But we need to see it as part of a whole, and we need to be sure that the standards that we are implementing are really doable and are congruent with the resource base that's available, because many of the standards, I think, are made without necessary reflection on what the resource base is. The standards are published, and there are some that are locally specific, there are some that are nationally specific, but I do think that we need to be re-looking at them, and I think that the Crisis Concordat will give us the opportunity to look at national standards, certainly for acute care, in a slightly different light.
Okay, we've got a hands up from Anne Flanagan from Cumbria. Unfortunately, I can't unmute you because you haven't used audio to log in. So if you'd like to write your question, Anne, I will be able to read that out to Dr. Holmes. I have another question from Adam. He says, is the balance of new developments right between preventing crisis and managing crisis?
That's quite a difficult question to answer, because I think that it's very area dependent, and I think that's why there are action plans for each different area, because they can address this imbalance in different ways. I think there are areas where, for instance, primary care do a really good job around managing mental health issues. There are other areas where there are significant shortfalls in that. I think that there are resource implications in both. And I think the resource and the skill set that is required in the two different areas are really so diverse that one can't really make easy comparisons, quite honestly. But I do think that there are significant gaps in both.
Okay, thank you. We've got a hand up from Jutta. Let me just unmute you so you can ask your question. Okay, you're unmuted.
Hello.
Hello.
Hello. Oh, hi. I was just wondering, I'm ringing from St. Luke's Hospice in Plymouth, whether the hospice movement has been involved at all in this Concordat, or whether you have made any links at all, or yeah.
Not to my knowledge. I might be wrong, but
okay.
Certainly I'm not aware of the hospice movement being involved.
Okay.
And I'm just looking at a list I've got. They might well be involved in locality areas, but nationally I don't think they're part of the national group, unless they're, not that I can see as a standalone organisation.
Right. It would be Hospice UK, you know, who's representing the local hospices. But okay, I haven't wondered seen, because it's such an issue, yeah, for us.
It is a huge issue. Yeah, absolutely.
And bereavement. Yeah.
Yeah. I mean,
okay,
that's not that shouldn't stop you from maybe looking at trying to involve yourself in the local Concordat group.
Yes. Yes. And how would I find out about that?
Well, I think if you speak to the local CCG, they should be able to tell you.
Okay, I will do. Lovely. Thank you very much. Very interesting.
Okay.
Thank you.
Thank you. Okay, it doesn't look like we've got any other questions. So again, if anyone thinks of any questions after the webinar is finished, please just drop us a line at the ESIP info email address. Oh, hold on, we have another question snuck in. Anne. Okay, so Anne says, you talked about the integration of urgent care teams. Do you have a view on whether urgent care teams should be separate specialist mental health teams or cover the whole of adult social care?
I think there's probably a need for a hybrid, quite honestly. I think there should be integrated teams with social care involvement. Certainly the crisis team that I work in has a number of social care employees that are managed within mental health under a Section 75 agreement, and that works really well. Obviously, we're responsible for a lot of the implementation of the Care Act out of ours as well. But I do think, and I think that that's important because it does come as part of a whole. I know that there are some areas where local authority and mental health don't have that same level of agreement, but I think it needs to be worked towards. But until such time, there will probably need to be separate teams. But I do think integration is vital.
Great, thank you. Okay, I think we'll bring this session to an end. Thank you very much for providing us with this presentation today, Dr. Holmes. It's much appreciated. And just a reminder to everyone that this recording of the webinar will be available on our website. And thank you very much for joining us. Goodbye.
Thank you.